Thank you so much, Claire. Hello, everyone. It's time to get into the nuances of shoulder hypermobility as it pertains to Ehlers-Danlos syndrome. We'll quickly go over the assessment pathways, the biomechanics, and some of the treatments. I think my mic is not working, so probably I'll just have to stay here. I don't have any relevant disclosures. I live in the beautiful city of Toronto, and I work as a medical director at the Good Hope Ehlers-Danlos Syndrome Clinic. This clinic was officially established in 2017 after collaborative efforts of patients and providers. There was some provincial funding which came from the Ministry of Health, led us to the establishment of this clinic. It's an interdisciplinary clinic, and last year we published this roadmap paper to kind of help others out there who are wanting or looking to establish an interprofessional service for individuals living with Ehlers-Danlos syndrome. This is a flow diagram that explains how patients kind of move through the clinic, but I wanted to focus on this part where it kind of explains the different services that the clinic offers. On the right side of your screen, you'll see different medical specialties. As we all know, autonomic dysfunction, be it cardiac dysautonomia, be it gastrointestinal manifestations, be it respirology, and kind of so on, go hand in hand with EDS. So we have a bunch of specialists who work with us on helping individuals with EDS to manage these symptoms. And on the left side of your screen is our self-management program, which contains physiotherapists and kinesiologists, exercise physiologists who maintain the rehabilitation program. We have 3 psychologists in our program, 1 social worker, and a dietitian as well. So it's kind of like it's not absolutely everything that we can provide to the individuals living with EDS, but it's still something that we have been able to get hold of. Now, coming on to the topic, let me tell you one thing straight. Shoulder is a very complex joint. Looking at it from the outside, it looks pretty easy as a shoulder, and the analogy kind of goes as similar to a car engine. My dad is an engineer, and when I was young, he would bring out some engines which would look kind of like easy from the outside, but when he would open them up, they'll be like a total mess. So it'll be like so many different things going around in that shoulder, which kind of actually lead to a smooth movement. And so in the next 15 minutes that I have remaining, we'll be talking about the biomechanics of shoulder joint, the specifics of the biomechanics as it pertains to individuals with EDS, a clinical framework of classification that we use and has been there for a quite long time, but not widely used. And then we'll look at some treatment principles based on that system. So morphologically speaking, shoulder, although is a complex, we can divide it into 3 categories of structures which kind of have a role in shoulder biomechanics. The first part is obviously the bony articulation of head of humerus sitting into the glenoid of scapula. The challenge is head of the humerus is 3 times bigger than the glenoid of the scapula, so the scapula doesn't completely fit it in. So it's kind of like hanging loosely in there, and it's then supported by soft tissue structures like capsules, ligaments, and other dynamic stabilizers like rotator cuff muscles. If we talk about the capsule and the ligaments, the capsule of the shoulder joint covers the joint, and it's also like a vacuum effect that exists in the capsule, which creates a negative pressure to kind of suck everything of the shoulder joint in and keep it in place. Interestingly, if you look at the case reports for patients with EDS who've been operated, a lot of MRIs would show you that there's a lot of inferior capsule laxity which exists in these patients. The next important structure is glenohumeral ligaments. There are a bunch of different ligaments which provide stability to the shoulder joint, but the most important one which I want to talk about is glenohumeral, and specifically the inferior glenohumeral ligament, which has got 2 different parts. The anterior glenohumeral ligament, which actually becomes taut when we are doing a movement of like an abduction and external rotation, kind of similar to like pitching a baseball. And then the other part is the posterior band here, which kind of plays a role and becomes tense and tight to maintain the function when we are doing flexion and internal rotation. This ligament is also, in most of the studies which have looked at EDS patients retrospectively after operations, shows that the ligament is kind of lax in these patients. Rotator interval is another soft tissue structure which kind of lies inside the shoulder joint and plays an important role in stability. If you look at this triangular area, this is the area which lies kind of inside the joint and is made up of a few different structures which contain the shoulder capsule, the ligaments I talked about, and the corner parts of the supraspinatus and the subscapularis muscle. The role of this rotator interval is to work kind of like as a suspension bridge to offload the stress of the muscles and the ligaments. Quite often in individuals who have EDS, not also just only in EDS, most of the time people who have shoulder instability, which is traumatic in nature, rotator interval is the area which is most often affected. Also in individuals who have degenerative rotator cuff tears, eventually leading to shoulder instability, it is the rotator interval which is kind of the culprit. Last part is the dynamic stability, which is provided by the rotator cuff muscles. If you look at the image, in the center of the image, there's a red kind of a line or a marker which shows that when we are abducting or when we are forward flexing our shoulder, the rotator cuff muscles depress the humeral head into the scapula, and they also try and depress the humeral head so that it's not kind of like touching on the top of the glenoid cavity or the acromioclavicular joint. So now if there's kind of like any dysfunction of any of these structures, it can eventually lead to shoulder instability or impingement or so on. Last but not the least, the scapular kinematics or the movement of the scapulothoracic junction is what is often overlooked in individuals who have EDS and also in others with shoulder hypermobility. What scapula does is that when we are trying to forward flex or kind of like abduct our shoulder, the scapula rotates upwards, it kind of tilts posteriorly and opens exteriorly. The reason why scapula does so is to maintain the subacromial or the acromiohumeral space so that we don't have any impingement or kind of like tears and so on. I'm also having some trouble with this pointer anyways. So if we kind of, now as we've seen, this is a lot of structures playing a role in stability of the shoulder joint. And how does it really applies to individuals specific in EDS? What really happens mostly in EDS is individuals have inferior capsule laxity. That inferior capsular laxity and the laxity of the inferior glenohumeral ligament produces abnormal stress on the rotator cuff muscles, and the rotator cuff muscles, they try to work, but after a certain period of time, they kind of try to give up, and the rhythmic motion that is happening between the rotator cuff muscles and the scapulothoracic muscles is lost. This results in an abnormal muscle patterning issue and poor dynamic stabilization, which eventually leads to instability, tears, Bankart Hills or Sachs lesions or labral tears and so on, causing pain and subluxations or dislocations. Think of it again as the model when you see if anything in this, any part in this engine goes wrong, the analogy is kind of like the engine is going to seize up and not work. The most common classification which is usually used for shoulder instability is the Thomas and Matson classification. You see there's two different categories. One in the Venn diagram kind of shows that the one in blue is the Tubbs category, or when a person actually has a fall or any traumatic event that results in a unidirectional instability and they have a Bankart or a Hill-Sachs lesion, the treatment is surgery. On the right side of the Venn diagram, you see there's an Ambry category, which is atraumatic instability, multidirectional in nature, bilateral, can be helped with rehabilitation, and if rehabilitation doesn't work, inferior capsular surgeries or shifts are done. The system, when it came out, it kind of served the purpose because it's very easy to categorize patients into two different stages, and it is also has an algorithm for treatment which people could follow. However, the challenge with using the system in EDS is in Ehlers-Danlos, patients have dynamic instability. So the shoulder instability is not really often not present when the shoulder is not moving, but it kind of starts building up when there's a movement, inflection, abduction, and kind of like so on. So the challenge with this system is it doesn't kind of go through the dynamic process of instability and address, if you see the middle part of the Venn diagram, the LEX patients who kind of develop any traumatic injury. Also think of a person who has, who maybe had a mild injury, and at that point of time there was no dislocation or subluxation, but what happened after eventually that they would start having dislocations, subluxations, or chronic pain. But at that point of time, they neither fit into a traumatic instability nor into an atraumatic instability. So that's the kind of a challenge with using the system in hypermobility or shoulder instability specific to Ehlers-Danlos syndrome. So the system which is used, has been there for quite some time, is the Stenmore classification. What it does is that it's got three polar extremes. The polar type 1 on the top of the triangle you would see is, think of a patient or a person who had a traumatic event like an athlete who fell down, broke their rotator cuff, and have shoulder instability. So that's type 1, traumatic. On the right side of the end of the corner of the triangle, you'll see the polar type 2. They're the ones who have, it's probably where individuals like EDS start with. They don't have any structural abnormality. It's all atraumatic in nature. Starts with capsular laxity and inferior glenohumeral laxity. And then the third type on the third end of the corner is patients who, or people who have abnormal muscle activation, which results in instability of the shoulder and perceived pains and dislocations or subluxations. And then there's, the boundaries of that triangle wherein a person can not only be having one specific subtype, but they could move between the type 1 and type 2, or they could move between the type 2 and the type 3, or they could be moving between type 3 and the type 1. So the system kind of encompasses a framework wherein a person who has instability, whether it's because of capsular or ligamentous issues, whether it's muscle patterning issues or structural issues, can still be addressed using this system. It's kind of a clinical presentation that this is one of the patients that I follow with shoulder instability and frank subluxations. Patients don't usually only complain of shoulder pain. If you look at the pattern of the diagram, the pain is in the entire shoulder, the upper extremity, and in the posterior image on the right side of your screen, they also have pain in the scapulothoracic region. So this is kind of what we are working with when we see patients with shoulder hypermobility in Ehlers-Danlos. Most commonly, this is how we see it. People will have like a sulcus sign or a drop or squaring of deltoid is what it's called. However, just having this squaring doesn't really tell us if the person has this subluxation because of EDS or not. Often people who have traumatic injuries or lax rotator interval, if you remember, can also have this kind of presentation. So what we need to do next is we need to look at specific tests of shoulder instability which are due to capsular laxity or inferior glenohumeral ligaments. There are more than 20 tests of shoulder instability that I know of. The ones which are used commonly, like sulcus sign, which I showed you in the slide prior to this, is not really specific to capsular laxity, because if there's a rotator interval deficit or injury, that could also present similarly. Apprehension tests, like posterior and anterior apprehension tests, I've never found helpful in individuals with EDS because they don't really have any apprehension even when their shoulder is half sitting out. So that's not what I usually use. The test that I use is one on the left side of your screen. It's called the Gage's hyperabduction test. What you do is, if you look at the right hand of the examiner, they're stabilizing the scapula, and with the left hand, they're passively abducting the shoulder. If it goes more than 105 degrees, that is suggestive of inferior glenohumeral ligament laxity. The other test which I use in practice is the load and shift tests on the right side of your screen, and you kind of stabilize the scapula with one hand, and with the other hand, you kind of translate it anteriorly and posteriorly. There's some subjective component to this test, but the more we do it, the more we get used to of how patients who are LEX actually have the amount of translation that is present in them. Normally, when a patient has anterior-inferior shoulder subluxation, which is common in EDS, or when they have non-EDS patients who present with this, what the providers would do is they'll ask for an X-ray looking for something called as a acromiohumeral distance, which is actually this distance they're looking for should be more than 1 centimeter or 10 to 12 millimeters. However, this doesn't really work for EDS because individuals don't really have increased acromiohumeral distance when we take an X-ray when in a standing or a sitting or a lying down position. So even if you have some kind of instability in shoulder subluxation, X-ray is not a really good modality in EDS to find out unless you really have a frank subluxation or dislocation that's going on. To work this around, this was a study which was published by the Belgian group. What they did is they looked at ultrasound as a dynamic modality to find out if they can still find out the acromiohumeral distance, which you see on the right side of your screen, kind of moving from 0 degrees of abduction to 45 and 60 degrees of abduction. They included 29 patients with EDS and 22 healthy patients. And you look at the Biden score is quite different in both the groups. What they found out was that there was a meaningful difference statistically that was found between the acromiohumeral distance when the shoulder was kept at 0 degrees versus 45 or 60. The challenge with using this in the real-time situation is we are yet to find out what is the pathological cutoff where we could really say in an individual with EDS whether there's dynamic instability in abduction of the shoulder or not. But I guess there'll be further studies looking at something more than that, and we'll probably get there. Another patient of mine, I want to come to scapular instability now. You look at the movements. This one is like really an extreme, but I just wanted to get a flavor of how the scapular model tracking really works in individuals who have shoulder hypermobility causing instability and subluxation. And this is an interesting study. And before I even go there, I'm going to show you now a few studies on this. There's incredible amount of work, I must acknowledge, has been done by a Belgian group and a Danish group, looking specifically at how the hypermobility in EDS is different from other forms of multidirectional instability and how to actually treat them. This is the first of the studies in which they looked at electromyographic activity of scapular stabilizers and glenohumeral other muscles to find out whether people with EDS have different muscle activity patterns as compared to other hypermobility groups or people who have multidirectional instability and normal healthy controls. What they ended up finding was that on the left side of the image, you'll see that patients who have EDS or hypermobility spectrum disorder, they had limited amount of upward translation of the scapula as compared to both the other groups. And also they had limited amount of posterior tilting as compared to the multidirectional instability group after the data analysis. What ends up happening with all these things is people end up getting some structural injuries at the end, Bankart lesions, Hill-Sachs lesions, capsular tears, and so on. I think I'm kind of running low on time, so I'm going to skip this slide, or maybe go over quickly. So yeah, in the patients with EDS, they kind of go with, they start first as atraumatic structural, end up developing some muscle patterning abnormalities, and then kind of eventually develop some traumatic injuries. Treatment principles, most important, again, with the type 2 and type 3 should be started with physical therapy and different kind of studies I'm going to show you if time permits. And if there's structural instability, they go to operative methods. Physiotherapy principles for EDS have not been there for a while, but for multidirectional instability, they have been there for quite some time. This is a recent review which summarizes different kind of physiotherapy treatment programs for atraumatic instability. All I want you to see is the principle which show these 6 different principles on how it should be addressed. Last 2 studies, this is another study by the Belgian group. They looked at high load versus low load in individuals with EDS, 16-week program. 2 groups, one group got high load, the other group got low load. And the group with the high load actually didn't mean that have to have more kind of like kilograms. It was a relative increment in the activity of the muscle. What they really found out was that high load activities were statistically superior to low load strengthening exercises in the self-reported function at 16 weeks. Another study, it's COVID pandemic time, home-based instability programs is what was done, again, by the Belgian group. They looked at the group 1 was the tailored exercise program, which was based on their previous study looking at the electromyographic data. And the group 2 was a standard regime, which includes proprioceptive exercises, some low load, and others. And they had 2 different outcomes. The first was the Western Ontario Shoulder Index, and the other was DASH, or the disabilities of arm, shoulder, and hand. What they found was that both the groups, the dashed line is the group 1, which is the tailored group, and the continuous line is the group 2. What they really found is both the groups really did well at the end of around week 24. Again, as my previous speaker, Dr. Rizk, was talking as well, we tell patients, oh, you go and exercise, you go and do this and do that. But a lot of time, their ability to participate in exercises is limited by pain. And these are kind of like a description of the different nerves which supply the shoulder joint. If you look at the interior, the one in blue is suprascapular nerve, the one in purple is the lateral pectoral nerve, and the one in yellow is the axillary nerve. This is a study which we done at looking at pain, targeting these nerves using ultrasound guidance. And so now, based on that study, what we do is we offer patients nerve blocks, diagnostic nerve blocks with local freezing. And if they get benefit from those blocks, we then do a radiofrequency ablation of the sensory articular branches of the joints. This is a ultrasound view of a lateral acromion. This is suprascapular, and so on. Again, the goal of these nerve blocks is not a cure. The goal is just to facilitate rehab, because rehab is mostly what helps them the most of the times. The last but not the least, not all the patients get benefited by physiotherapy and pain management. Some have to get surgery. There are different kind of repairs, anatomical and non-anatomical. I'm not going to go into details, but on the basis of the limited data that has been published, the structural repairs kind of work better with the non-structural repairs. What it really means is that structural repairs are anterior capsular plication or the capsular raphe. They work better than putty plat or Latarjet, wherein people are trying to take one part of the bone, fix it on the other part, and put kind of like a block. Those kind of surgeries don't work. Surgeons usually have a tendency to propose the surgical technique which they are kind of well-versed in. So this is a word of caution for individuals with EDS. If they get surgery, they should get anatomic repairs and not usually non-anatomical repairs. Take-home message, again, we talked about the biomechanics, why there's capsular laxity. There's a clinical framework pattern on how it should be addressed, and the treatment principles. Thank you so much, and I'm sorry for taking some extra time.